Okay, go ahead and get started. Thanks for coming and joining us today. I know it's Surge Red as usual. One of these days it'll be Surge Green, and we'll be able to say that. If you guys need anything, remember Sal is our TV this week, so please let her know if you need anything. But today I'd like to introduce our speaker. I think we've all worked with her since she's been here, and we all appreciate the work that she does for us. It's Charleen Jacobs. I'm here to talk about sickle cell. So a little bit about Charleen, if you guys don't know. She's one of our board-certified adult health practitioners, specialized in sickle cell disease here at Mount Sinai's adult sickle cell program. She has over 13 years of experience in the nursing profession. Recently graduated with a bachelor's at Adult University in 2006, then working as an ICU nurse until she received her nurse practitioner degree in 2014. She initially worked at Montefiore in the pain management program as well as their sickle cell center at Montefiore. Then came here to join us in November of 2017, which feels like yesterday.
Yes.
Charleen continues to be a nurse leader and educator, and has been awarded numerous awards, including the Committee Athletic Day Service Award from the Queen Sickle Cell Advisory Network, and has also published in the Journal of Hematology, and presented her work at local and national conferences. So we are so happy to have you today to give us an update on sickle cell treatments today. Thank you very much.
Thank you.
Oh, yes. We're having a little bit of technical difficulties, so for some reason the full screen is not working, so she'll have to just unfortunately go through it in the editing view, so we apologize for that.
Well, thank you guys for inviting me to speak at Hospitalist Ground Round. So I'm excited to be here, and you guys all know me from the sickle cell program. And what I'm going to discuss today is the advances in the treatment of sickle cell disease with L-Glutamine, Crizanlizumab, and gene therapy. As you know, for a long time, the mainstay for sickle cell treatment has been hydration, pain meds, hydroxyurea, folic acid, mainly palliative treatments for sickle cell. So these are some new things that are down the pipeline and some that have already arrived. So I have no disclosures. So today's objectives are to provide clinical updates on the treatment of sickle cell disease with L-Glutamine, and to describe emerging therapies for sickle cell disease with Crizanlizumab and gene therapy. So I just wanted to quickly go over sickle cell disease. I know that we all take care of patients, but it will be a nice refresher to just understand where we are and where we're going. So sickle cell disease occurs globally in about 300,000 births annually. It affects about 100,000 people, 70 to 100,000 people in the United States. It's about one in every 365 Black or African American births, or one in every 1,400 Hispanic American births. There's about 1 in 13 people born with the trait, and in New York City, we have about 8,000 people living with sickle cell disease, mostly in the Bronx and Brooklyn. So the genetics of sickle cell disease, it's basically based on hemoglobin, which consists of 4 protein units. There's 2 alpha globins and 2 beta globins, and the HBB gene causes beta globin synthesis, and there's a mutation on that gene at chromosome 11, and that mutation causes abnormal beta hemoglobin, causing the sickle cell, hemoglobin S. So because of that genetic mutation, it causes a cascade of many different things, but it really causes hemoglobin polymerization, and that's due to the deoxygenated state, and then it's accelerated by a high concentration of hemoglobin S, which leads to vaso-occlusion. When vaso-occlusion occurs, it starts an inflammatory mediator response, and it releases prostaglandins, histamines, bradykinin, and that's due to the tissue damage. Then there's ongoing microvascular occlusion that leads to ischemia, tissue damage, and then there's also adhesion of the sickle erythrocytes and leukocytes to the endothelium, and that's initiated by P-selectin. I'm specifically talking about P-selectin because it's involved in one of the medications. And then there's endothelial destruction and nitric oxide depletion, which leads to stroke, pulmonary hypertension, and priapism. Sorry about this screen situation. So the effects of sickle cell disease, as we all know, is unpredictable pain crisis and organ damage with stroke, retinopathy, pulmonary hypertension, sickles, hepatopathy, kidney disease, AVN, and leg ulcers. There's also chronic pain is associated with poor health-related quality of life, lower socioeconomic status, stigma, and early death. In people with SS disease, the average age of death is about 40 years old, and that's the most common type of sickle cell. So that's probably the most kinds of people that we see here in the hospital, and that's usually the most severe type. So current treatments for sickle cell disease is hydroxyurea, and that was approved back in 1998. And there was no real movement in development of medications for sickle cell disease since then, until L-Glutamine, which is in Dari, and that was FDA approved in 2017. Other things are penicillin prophylaxis for anyone who had a splenectomy up to the age of 5, or blood transfusions, could be either for pain or stroke, IV fluids, folic acid, and analgesics for pain. And there really hasn't been anything since L-Glutamine. So we'll talk about the new therapies on the market and some that are on the horizon. So that's going to be L-Glutamine, Crizanlizumab, and gene therapy. So first we'll talk about L-Glutamine, which is Indari. And that was FDA approved in July of 2017. And it was based off of this multi-centered randomized placebo-controlled double-blinded study. And the inclusion criteria was 2 crises per year with a history of SS or S-beta-0 thal, because they both mimic each other as far as their presentation. And they had to be on a stable dose of hydroxyurea for 3 months. It was a 48-week treatment period, and the mechanism of action is not fully understood in L-Glutamine, but we understand that it helps reduce the oxidative stress. So 230 people were enrolled. They are randomly assigned in a 2-to-1 ratio. 152 patients got L-Glutamine, and 78 patients got placebo, and they got about 10 to 30 grams per day. And the endpoints that they wanted to understand was the number of pain crises a patient would have during a 48-week period, and their secondary endpoints was the number of visits, outpatient, ED visits or outpatient treatments, number of hospitalizations, or any changes in the hemoglobin or hematocrit and reticulocyte count. So this study showed that 63.8 people completed, 68.3% completed the trial for L-Glutamine, and 75.6 of the placebo group completed the trial. It found that there were 25% fewer crises, 33% fewer hospitalizations. The median time to first pain crisis was 84 days in the L-Glutamine group versus 54 days in the placebo group. The median time was to second pain crisis was 212 days in the L-Glutamine group versus 133 days in the placebo group. They found fewer acute chest syndromes, but it wasn't statistically significant, and no significant change in the hemoglobin and retic count. So this just shows the findings of the L-Glutamine study, and really it's just showing the comparison of the number of pain crises over that 48-week period compared to the placebo, and then the first sickle cell pain-related pain crisis and the time to second sickle cell related pain crisis. So after it was approved, we started prescribing it in November of 2017, and we continue to prescribe it here. So the indications for it is to reduce the acute complications of sickle cell disease in ages grade 5 or older, and it's weight-based. So it's based, you can either give 1, 2, or 3 packets twice a day, depending on their weight. And it's easily mixed in water, juice, or yogurt. It comes in a little powdered form, and you should mix it in about 8 ounces of water. The most common adverse effect or adverse reactions are constipation, nausea, headaches, abdominal pain, pain in extremities, back pain, or chest pain. Most patients complain to us that it really makes them feel bloated, or sometimes we have to explain to them that you might feel like you had a complete meal, and that's what they complain of sometimes. This causes some adherence issues because of that. So it's renally excreted, so we want to avoid it in patients with renal disease. And it can be continued while a patient is hospitalized. So if the patient, if we have one of our patients here, should really ask them if they are taking Indari and if they can have their family member bring it from home. And that's what we've been sort of talking to patients about too. It should be used in conjunction with hydroxyurea. It's not a replacement for hydroxyurea, but it's supposed to be something to really help in treating their pain. But some people really describe it as they're not really too fond of L-Glutamine because they thought that the trial was a small sample size, and they weren't very impressed with patients still continuing to have, back pain, chest pain, which are common pain complaints in patients with sickle cell disease. So some people, some of the hematology folks are on the fence about it. But since, like I said before, it's not on formulary, so they have to bring it from home. Yes.
So you said some of the most common side effects are chest pain, back pain, and as you know, those are some of the side effects,
exactly.
Some of the manifestations of sickle crisis. So does this make the patients at least perceive that their sickle crises are getting worse?
It's, to be honest with you, it seems very variable because the patients that we do have, it really depends from person to person. Some people say that they have more energy, they feel great, they've tried L-Glutamine from the vitamin store before, even though this is like a pharmaceutical grade one, which is completely different than what, is being sold in GNC. But, most people say that it really sucks and they don't like taking it. And, just to be honest, some people, they'll say, like, I still have pain. It's making me anxious. I don't know if it's like a contextual thing why they're like, I'm taking this new medicine and I just don't feel right because I'm not familiar with it. Or is it a legitimate pain? Because sometimes they just have chronic pain in their chest. And then the reports of the pain that were in the study, we're not sure if that was because of L-Glutamine or was that their chronic chest pain.
You know if L-Glutamine has been proven to decrease ER visits or hospitalization? It decreases pain crises.
Right, but it didn't make a big effect on the admissions. Yes, not significantly.
Did that study look at any changes in CAT control departments?
No, the endpoints were just number of pain crises per year, how many hospitalizations, and changes in the hemoglobin and hematocrit and retic. That's it.
And do you know what it costs per year, roughly?
It's about $3,000 to get that's for 1 month, per month. Per month. Yes. So that brings us to the next point. That brings us to the next point. The limitations are the high cost. It's about $3,000 per month for adults. It's about $1,000 per month for children. So I share the room with the ADS-NPs, so they see me faxing lots of forms and paperwork to insurance companies to get approval for their medications. And you have to be very specific in your documentation to get approval for it. But it's a major barrier for people who have commercial insurance, actually, compared to our other, publicly insured group. So most times people who actually have their private insurance, they're not getting covered. And another thing is that we have to find specialty pharmacies that are not in the area. They are coming from Texas, and we've just signed on with another pharmacy out in the Bronx that's now been prescribing it to patients. And that's another major limitation in having access to the medications for them.
Try clicking
yes.
stop sharing at the bottom and see if that turns it off. Maybe.
Oh, I don't know what it did.
Actually, don't do that.
Should I go back to share my screen?
Yeah, I guess.
Okay, I think it's on.
Sorry. It's,
No, go
I
ahead.
know it's annoying, but unfortunately, we're getting the recording. So.
Yes.
All right.
So Gina and I spend a lot of administrative time with prior authorizations. A lot. And then on top of that, the adherence issues are another problem because they have to mix it. It's twice a day. They don't feel that great. Sometimes they feel too full afterwards. So some people are just not taking it because of that. And when we communicate with our specialty pharmacies, the patients either have changed their phone numbers, have a hard time getting in touch with them. So there's a delay in receiving the medication because we might not see them for another month or two for sickle cell follow-up. So it's very hard to get in touch with them in that sense. So that's L-Glutamine. So we have some promising clinical trials coming along with Crizanlizumab and gene therapy. So I'll be talking about Crizanlizumab, and that is to prevent sickle cell pain crisis. And this is from the SUSTAIN study. It's a phase 2 multi-center randomized placebo-controlled double-blinded 12-month study. And it's Crizanlizumab is a human monoclonal antibody. It binds to P-selectin, so it blocks P-selectin glycoprotein ligase. And the endpoint of that is to determine the effect of Crizanlizumab during 52 weeks of treatment. So the inclusion criteria for this is pretty much all the genotypes of sickle cell. You have to be 16 to 65 years or older, 2 or more pain crises in the last 12 months before enrollment. And if you're on hydroxyurea, it has to be for 6 months on a stable dose without any dose alteration. And the exclusion is anyone who's on chronic transfusion therapy. So the study design was a randomized 1:1:1 ratio with low dose Crizanlizumab, high dose, and placebo. And so patients were given a loading dose 2 weeks apart, and then a maintenance dose was given every 4 weeks. It was given through an IV over 30 minutes, and they got 14 doses in total. So the primary endpoints were the annual rate of sickle cell related pain crisis over 1 year, and acute chest, hepatic sequestration, splenic sequestration, and priapism were included in crisis events. They were excluded in the L-Glutamine group, but they considered crisis events to include these. Secondary endpoints was the annual rate of hospitalizations, uncomplicated crisis, and acute chest syndrome, and times to first and second pain crisis. So the results were, this was done in 198 patients, 60 sites across the world, really. It was in the US, Brazil, and Jamaica. There was 129 people completed the trial. There was a 43% lower rate of pain crisis per year in the high dose group, and a 32% lower rate of pain crisis even in the low dose group. And the median crisis per year in the high dose Crizanlizumab group was 2.43 days of crisis versus 3.58 in the placebo group. Patients with 2 to 4 crises per year decreased to 1.14 in the high group. 5 to 10 crises per year decreased to 1.97 in the high dose. So that's pretty significant. I'm so sorry, guys. Even in the more milder types of sickle cell, SC, S0, beta thal, S beta plus thal, there were 0.99 crises per year versus 2 in the placebo. So these were pretty significant, and there's a lot of talk in the hematology world about this medication. Also, secondary endpoints, there was not a significant difference in the rate of hospitalizations, but the time to first sickle cell crisis was 4.07 versus 1.38 months. The second time to second sickle cell crisis was 10.32 versus 5.09 months, so those were statistically significant. There was a rate of the rate of uncomplicated sickle cell crisis decreased also to 1.08. The rate of ACS, hepatic sequestration, splenic sequestration, and priapism, no significant differences. Quality of life and brief pain inventory questionnaire, no significant changes, and no significant changes or differences in the hemolysis labs. So this it's too small for you guys to really see that, but it's really just demonstrating the comparison between the high dose crizanlizumab, the low dose, and the placebo. It seems like the high dose crizanlizumab is making the most significant difference, and the low dose is not doing much of a difference. So the pharmacokinetics and pharmacodynamics of this steady state is reached after the loading doses, and then the mean trough concentrations are between 10.5 to 15 micrograms per ml, and it was effective in inhibiting the p-selectin binding throughout the treatment phase. So some safety concerns that were brought up, the adverse events, there were quite a few. Pyrexia, influenza, pneumonia, headache, back pain, arthralgia, pain in the extremity, urinary tract infection. There were 5 deaths reported. In the high dose group, it was from acute chest and another one from endocarditis or sepsis. The low dose group was acute chest that led to aspiration, respiratory failure, and vascular congestion. And in the placebo group, one person had right ventricular failure, and one person had a VOC that was complicated by stroke, sepsis, and a venous thrombus embolus in the embolus in the right lower extremity. So some other considerations that are coming out are obviously continued follow-up for the efficacy and safety of crizanlizumab, monitoring for late neutralizing antibodies, and also it is costly. It didn't mention in the study how much it costs, but I understand that it's a pretty costly medication. And also it will be delivered, every month. So that will change how we in the hematology world probably practice.
That's more related to the higher dose or the lower dose,
What is that? Oh, it was in the high dose group, but it was in all 3 groups: high dose, low dose, and the placebo group. Yeah. And so that's the consideration, was the cost and distribution to patients, because it will be costly. It will change how we practice treating sickle cell as well, because that would be considered an outpatient treatment most likely, if it's a once a month kind of thing. Okay, so gene therapy is our another exciting thing for sickle cell disease, because this is a curative treatment for sickle cell disease. So what about stem cell transplant? We've done stem cell transplants, but there are many pros and cons to it. Some of it is that it's really a curative treatment for people who have severe sickle cell disease, and usually severe sickle cell disease that's cited in the literature are people who have many pain crises per year, history of stroke, or chronic transfusions are usually the main indicators, or high TR-jet also. So those are the pros for curing it. It's highly successful in matched siblings. It's better tolerated in younger patients with less end organ damage. It improves their quality of life, obviously, and it decreases pain and improves end organ damage. But some of the cons about it is that you have to have chemotherapy beforehand. Matches are not widely available. It's very difficult to find a match. About 80% of patients who enroll do not find matches. It's not well tolerated as patients age because of their end organ damage. And then there's long-term side effects as infertility and chronic GVHD. And there's high risk for GVHD rejection, and mortality in this group. So these are problems that we're having with sickle cell stem cell transplantation. So gene therapy for sickle cell disease is basically what gene therapy is delivery of a DNA encoded gene into a cell to treat a disease. So the virus that is used for this is the lentivirus, and it's an inactivated form of HIV virus, and it's done by using autologous hematopoietic stem cells, and that helps with reducing the risk of GVHD and rejection because it's coming from the patient's own self. So currently there are 6 clinical trials for gene therapy out there, and we are actively referring our patients to some of these centers as well. So I just wanted to have this graph here and just show the different types of gene therapy. What we're going to be talking about specifically is gene addition at the top, but there's also gene correction and hemoglobin F induction. So for gene therapy, there is the Bluebird trial, and that's the anti-sickling beta globin variant, and that's expressed as beta AT87Q, and this is the lentiglobin BB305. So pretty much you're gonna take the stem cells from a patient, and you're going to transduce this BB305, and it substitutes glutamine and restores the beta globin to the HBB gene function, and is expressed as hemoglobin A87Q. Very, while I was looking through this, because it's a fairly new thing for us too. So when I was looking at the graphs, and I'm like, what do they mean by that? But it's the new expression of the hemoglobin A in the person's body. So the mutation in the beta globin sequencing has strong anti-sickling properties. So I'll talk about one that came out of the New England Journal of Medicine, but we do know of other patient who was here also, and we all have watched, or many of us have watched, the 60 Minutes special that came on about a month ago about gene therapy. But in this particular case, it was a 13-year-old male with severe SCD, and what they did is they did a bone marrow collection twice, one for the actual transplantation, and the other one was just for backup. And they used the CD34 cells, were transduced with the lentiglobin, and he had myeloablation prior, and then they infused the transduced cells. So by day 38, they had complete neutrophil engraftment. The hemoglobin A87Q was increased between 3 to 6 months. Day 88, the blood transfusions were stopped. Day 98, he had platelet engraftment, and by month 15, the hemoglobin AT87Q was increased to 48%, and the hemoglobin S was down to 49%. So that, in essence, is sort of like sickle cell trait status. And the hemoglobin increased from 10 grams per deciliter to about 11 grams per deciliter. So that's, I don't have a pointer, but at the lower end, you'll see that the hemoglobin A, because the patient, the lower graph, the hemoglobin A is slowly decreasing. That was the transfused blood, while the hemoglobin AT87Q, I know it's very hard to see on this, increased to 48% by month 15.
So this patient was sitting in the hospital for 91 days?
No, the patient was discharged at day 50.
Day 15.
50. Yes.
Okay.
Mm-hmm.
Okay.
No, not 15 months, but he was followed, obviously, very closely afterwards. Sorry, I missed that point. So that's very promising. So after that, so the endpoint, the 15 months post-transplant, there were no sickle cell related events. Pain meds were discontinued. Hydroxyurea was discontinued. The patient returned to school and full physical activity. The MRI of the head had no new infarcts, no new bone deterioration from AVN in the MRI. His ferritin decreased and iron overload via MRI was decreased as well. So as we all know, we all may have or may have not watched Janelle's story on 60 Minutes. And it was a young lady who had sickle cell disease, and she was also cured of it using gene therapy. And this was her getting her first transfusion of the lentiglobin here on day 1. And this is her afterwards doing karate. And she really, and if you ever watch the video, she's doing karate, and she said she felt great. She had more energy. She didn't have any pain. Doing karate didn't cause another crisis. She was flipping people over on the mat. So it was actually quite an amazing story, and we've been sharing it with our patients a lot. And you know, many patients are very open to it, but they're also concerned, obviously, about the lentivirus portion of it and it being a deactivated form of HIV. So after that, we have our own Mount Sinai patients share their perspective and experience, and Gina was part of that. And she was on CBS the next morning. And you guys probably know a few of these faces: Ernie Cabral, Jamal Fowler, Sidra Stewart. And they had mixed feelings, you know, about about the treatment. And one of the main things Sidra brought up was actually not even about the HIV lentivirus, but more so about her identity as a person with sickle cell disease, because she felt as though persons with someone like herself, she really works hard in trying to strive to be a normal person functioning in society, and that is what gives her that will, and that's what gives her her identity. Versus, you know, now if you take that away from her, how does she, you know, what is she going to identify with? It won't be another sickle cell person trying to strive for something. She'll just be considered part of, you know, every other person who has roles and responsibilities. There won't be any quote unquote excuses for it. We also have another patient who was a patient of ours who was cured. I don't know if you guys know this person. His name is Kirti Dasu. He came and spoke at our most recent sickle cell event last year to talk about his experience after being cured with gene therapy. And he is, you know, living a full functional life. He was very debilitated with pain prior, and a lot of hospitalizations or would get very sick when he was admitted. And he's now pretty much cured and going about his life in college and doing very well. So things to consider for gene therapy for sickle cell. The cost for gene therapy is very expensive. I actually just saw this article this morning on my way to work to see how much gene therapy costs, and it's about $500,000 to $1 million. The cost of sickle cell disease is very expensive throughout the lifetime as well, but you know, do you cure the disease, or do you continue the same modalities? It would be very hard to kind of make that choice. But also in Europe, it's equally as expensive, $370,000 to upwards of $900,000 in Europe. So things to also consider, obviously, is there needs to be a lot more long-term follow-up for the efficacy and safety of this. Any questions or comments? Yeah. Mm-hmm.
Considering it's a amino acid, we produce it in our body.
Mm-hmm.
So one question is, you mentioned that it reduces oxidative stress.
Yes.
What are the proposed mechanism? How actually it does that?
No. This.
The manufacturers are concerned about the mechanism of action because obviously you would people would like to know. They have a curative mechanism which is basically produces NP, which is required to allow the lymphocytes to be produced more, but they don't really know that.
naturally.
Mm-hmm.
Is there any, like ingesting extra amount of that? Is there actually any side effect or toxicity for
The only thing that's been reported really as far as tuck is that since it's, or we have been cautioned to be cautioned, is in people with renal disease and because it's renally excreted, but we haven't heard of any toxicities as yet. So I think that's something that would probably we'll learn more. A lot of the information that we have, since we've only been doing this for a short period of time, is that there's still more to be learned about it. You know, a lot of the things that we're telling you are kind of anecdotal from what we're seeing in practice.
And on the official label, there's no official contraindications, but it was a trial when people were so we've been cautioned to.
so they can actually use that side
Yeah.
So in the clinical trials, the placebo versus the treatment group, there was no statistical difference between the two groups in terms of side effects. So the side effects that Charleen reported, greater than 10% for nausea, headache, leg pain,
Mm-hmm.
and
Stomach.
So those were the only significant side effects that were reported in the clinical trials. And again, they were no greater than placebo.
So for the gene therapy, I think you said it starts with sort of an induction chemo, like wiping out the
Yes.
nasty bone marrow.
Yeah.
Can you describe that for us? Like how intense is it? I mean, is there a mortality from that, or is there?
Well, I haven't heard of any mortality from it because this was just a case report. And so far, you know, I haven't heard anything about mortality from gene therapy because of that. But they did not really describe the actual chemotherapy portion of the trial. They just said that he was induced and given myeloablative treatment, and then it went on into the remaining. There was no real. It was buse buse bufo. Thank you. Yes, thank you.
What do they use gene therapy? I know we don't have it here at Sinai, so which institution?
We are referring patients to Columbia University to do it, and our other next place closest to us is NIH. Oh, oh. We do. I'm on the team for that too. Yes. So they have Stride here that is for stem cell transplant though, and we are actively recruiting patients for that as well for severe sickle cell disease. You have to have 6 or more crises over a 2-year period or history of stroke on chronic transfusions and history of pulmonary hypertension are the main things that we're looking for those patients. It's been hard to recruit patients, and also we've typed quite a few patients also, and they haven't had any matches. So after we have exhausted that, some patients are still very interested, and we usually would refer them to Columbia if they're still interested. But there's sort of like a bottleneck effect going on at Columbia because a lot of people are interested in it, and there's a wait list.
Is any of this being funded by any of the research being funded, or is it being paid for by insurance?
If some of it, actually we referred a patient there, and they said that they did not take his insurance, so it's their insurance is paying for it. And the same thing with stem cell transplant as well. It's insurance paid for it, and that's another limitation in all of this is having that access to the care. Mm-hmm.
It's like Fidelis denied it for gene therapy, but
Yeah, it's quite variable. Mm-hmm. Any other questions? questions?
Thank you very much, Charleen.
You're welcome.